What is the standard minimum target activated clotting time, ACT, required before initiating cardiopulmonary bypass to prevent catastrophic circuit thrombosis? A. 150 to 200 seconds. B. 250 to 300 seconds. C. 400 to 480 seconds. D. Greater than 800 seconds. Answer: C. 400 to 480 seconds. Explanation: contact between blood and the massive foreign surface area of the CPB circuit triggers rapid coagulation. To completely inhibit the clotting cascade on bypass, an ACT of at least 400 to 480 seconds is standard. Initiating CPB with an inadequate ACT risks acute thrombus formation within the oxygenator and arterial lines. During CPB, an occlusion or absolute kinking of the venous return line will directly cause which rapid clinical sequence? A. Rapid emptying of the venous reservoir and a subsequent drop in arterial flow. B. Rapid overfilling of the venous reservoir and a spike in arterial line pressure. C. Immediate reverse flow through the arterial cannula. D. Severe vacuum creation inside the oxygenator. Answer: A. Rapid emptying of the venous reservoir and a subsequent drop in arterial flow. Explanation: if the venous line is kinked, blood stops returning from the patient to the circuit. The arterial pump will continue drawing from the venous reservoir, emptying it rapidly. Once the reservoir empties, the level sensor will sound alarms and stop the pump, or air will be drawn, leading to a crash in arterial delivery. When setting up a CPB circuit utilizing vacuum-assisted venous drainage, VAVD, what is the maximum recommended negative pressure safely applied to the venous reservoir? A. -10 to -20 mm of mercury. B. -30 to -40 mm of mercury. C. -80 to -100 mm of mercury. D. -150 to -200 mm of mercury. Answer: B. -30 to -40 mm of mercury. Explanation: while VAVD is highly effective for improving drainage through smaller cannulas, negative pressure should generally not exceed -40 to -50 mm of mercury. Exceeding this threshold significantly increases the risk of drawing air past the venous cannulation site, air pulling, severe hemolysis, and structural collapse of the circuit components. Which dedicated component of the CPB circuit is specifically designed to safely decompress the left ventricle and prevent distension during aortic cross-clamping? A. The cardiotomy section. B. The aortic root vent. C. The left ventricular, LV, vent. D. The retrograde cardioplegia line. Answer: C. The left ventricular, LV, vent. Explanation: blood from the bronchial veins and Thebesian veins continues to enter the left heart even during CPB. If the aortic valve is competent, this blood can pool, causing left ventricular distension, which elevates wall stress and causes ischemic myocardial injury. The LV vent actively aspirates this blood back to the cardiotomy reservoir. What is the fundamental safety concern regarding gaseous microemboli, GME, generation when using a roller pump for cardiotomy/field suction? A. Roller pumps destroy the platelets, turning them into gas bubbles. B. Drawing a mixture of air and blood through a roller pump crushes air into microscopic bubbles that are difficult to filter out. C. Roller pumps create an ultra-high vacuum that causes blood to boil at room temperature. D. The friction of the rollers warms the blood too fast, causing dissolved gases to come out of solution. Answer: B. Drawing a mixture of air and blood through a roller pump crushes air into microscopic bubbles that are difficult to filter out. Explanation: field suction lines constantly aspirate a mixture of air and blood. When this turbulent mixture passes through the high shear environment of an occlusive roller pump, the air is mechanically sheared, whipped, into millions of gaseous microemboli. These microbubbles must be thoroughly defoamed and filtered in the cardiotomy reservoir before re-entering circulation. Why is the purge line on an arterial line filter left slightly open during cardiopulmonary bypass? A. To continually deliver a low dose of heparin directly to the filter. B. To act as a constant escape route for any microbubbles trapped at the top of the filter housing. C. To divert excess blood pressure away from the patient's aorta. D. To measure the pressure drop across the filter membrane. Answer: B. To act as a constant escape route for any microbubbles trapped at the top of the filter housing. Explanation: the arterial line filter traps air bubbles because buoyant air naturally rises to the top of the filter housing. A small, continuous purge line runs from the top of this filter back to the venous reservoir, ensuring that any trapped air is constantly flushed out of the systemic line and sent back to be defoamed. During the rewarming phase of CPB, what is the maximum safe temperature gradient between the water and the heat exchanger and the patient's blood to prevent gas solubility disasters? A. 2 circ C. B. 4 circ C to 6 circ C. C. 10 circ C. D. Temperature gradients do not matter as long as the blood stays below 37 circ C. Answer: B. 4 circ C to 6 circ C. Explanation: gas solubility in liquid decreases as temperature increases. If cold blood is warmed too rapidly by highly heated water, dissolved gases, like oxygen and nitrogen, will abruptly come out of solution, forming dangerous microbubbles in the bloodstream. The temperature gradient between the water and the blood should never exceed 4 circ C to 6 circ C, and blood temperature should never exceed 42 circ C at the heat exchanger outlet. If a perfusionist switches from a traditional crystalloid prime to a retrograde autologous priming (RAP) protocol, what is the primary clinical safety objective? A. To lower the patient's core temperature faster. B. To reduce hemodilution and decrease the need for homologous blood transfusions. C. To guarantee an sterile circuit environment. D. To prevent protamine reactions at the end of the case. Answer: B. To reduce hemodilution and decrease the need for homologous blood transfusions. Explanation: the CPB circuit is typically primed with 1 to 2 liters of acellular crystalloid fluid, which dilutes the patient's blood upon initiation, hemodilution. The RAP technique uses the patient's own blood pressure to carefully displace this clear crystalloid prime out of the circuit into a waste bag before bypass starts, preserving a higher hematocrit and minimizing transfusions. An electronic bubble detector is a crucial safety device on the CPB circuit. On which line is it universally placed? A. The main venous return line. B. The cardiotomy suction line. C. The arterial line, downstream of the arterial line filter. D. The water lines of the heat exchanger. Answer: C. The arterial line, downstream of the arterial line filter. Explanation: the bubble detector is the absolute final safety gate before blood enters the patient. Placed on the main arterial line after the filter, its role is to catch any micro or macro air bubbles that managed to bypass all previous safety filters and reservoirs. If it senses air, it immediately sends a signal to stop the arterial pump. What is the clinical implication of a high-pressure drop, transmembrane pressure, across a hollow fiber membrane oxygenator during CPB? A. The gas flow, FiO2, is turned up too high. B. The fibers within the oxygenator are likely clotting off or fouling, restricting blood flow. C. The patient has become profoundly vasodilated. D. The venous reservoir is low on blood. Answer: B. The fibers within the oxygenator are likely clotting off or fouling, restricting blood flow. Explanation: transmembrane pressure measures the resistance to blood flow across the oxygenator bundle. A steadily rising or abruptly high pressure drop across the device indicates that the tiny channels between the fibers are becoming obstructed, usually by fibrin deposits or microscopic blood clots. This is a warning sign of potential oxygenator failure. Why must the gas flow, sweep gas, to a membrane oxygenator be completely turned off if the blood flow through the pump is stopped during a surgical pause? A. To prevent the oxygenator fibers from freezing. B. To prevent the accumulation of toxic levels of carbon dioxide in the reservoir. C. To prevent hyperoxia and gas embolization across the dry membrane into the stagnant blood. D. To conserve the hospital's central oxygen supply. Answer: C. To prevent hyperoxia and gas embolization across the dry membrane into the stagnant blood. Explanation: if sweep gas continues to flow while blood is stagnant, gas pressures inside the fibers can become high relative to the unmoving blood. This pressure differential can drive gas bubbles directly across the microporous membrane into the blood phase, creating an air embolus that will be pushed to the patient the moment the pump is restarted. In the setting of an unexpected electrical power failure in the operating room, what is the first safety priority for managing a roller pump-driven CPB circuit? A. Abandon the circuit and immediately initiate manual chest compressions. B. Hand crank the arterial pump at the appropriate RPM while ensuring adequate circuit volume. C. Administer massive doses of vasopressors to the patient. D. Drain the venous reservoir completely into the patient. Answer: B. Hand crank the arterial pump at the appropriate RPM while ensuring adequate circuit volume. Explanation: all modern CPB machines feature internal backup batteries, but if these fail, every primary pump head is equipped with a mechanical hand crank. The perfusionist must immediately deploy the hand crank to maintain systemic perfusion and myocardial protection, carefully watching lines to ensure air is not introduced. What component is integrated into the CPB setup to allow for the concentration of the patient's blood by removing excess plasma water and crystalloid during the case? A. An arterial bubble trap. B. A hemoconcentrator, ultrafilter. C. A cardiotomy defoamer. D. A de-airing valve. Answer: B. A hemoconcentrator, ultrafilter. Explanation: a hemoconcentrator utilizes a semi-permeable membrane that uses a pressure gradient to filter out water, electrolytes, and small inflammatory molecules from the blood while retaining cellular elements, red cells, platelets, and large proteins. It is used to reverse excessive hemodilution and increase the hematocrit without transferring cellular volume out of the circuit. What is the structural purpose of the one-way valves placed in the vent lines, such as the aortic root or LV vent lines, of a CPB circuit? A. To prevent blood from accidentally running backward into the heart if the vent pump stops or reverses. B. To keep the vent lines pressurized at plus 100 mm of mercury. C. To allow the surgeon to use the lines for drug delivery. D. To filter out bone fragments. Answer: A. To prevent blood from accidentally running backward into the heart if the vent pump stops or reverses. Explanation: vent pumps are typically roller pumps. If a vent pump is stopped or accidentally turned in the reverse direction, the column of blood inside the tubing could flow backward directly into the patient's cardiac chambers. One-way valves ensure that flow can only move from the heart toward the cardiotomy reservoir. If an air-to-blood leak occurs within a hollow fiber membrane oxygenator, what physical law dictates that air will cross into the blood phase? A. The hydrostatic pressure of the blood phase dropped below the gas phase pressure. B. The blood temperature dropped below 20°C. C. The sweep gas flow rate was lower than the blood flow rate. D. The patient developed a high systemic vascular resistance. Answer: A. The hydrostatic pressure of the blood phase dropped below the gas phase pressure. Explanation: in microporous membrane oxygenators, gas and blood phases are separated by microscopic pores. Fluids do not cross because the membrane material is hydrophobic, and the hydrostatic pressure of the blood phase is kept higher than the gas phase pressure. If the blood phase pressure drops below the gas pressure, gas will immediately cross the pores into the blood, causing massive air embolisms.